So hello everyone. My name is Tim Brown. I'm the Vice Chairman here at Hope2Sleep. As moderator for this evening, it's my pleasure to welcome you all to the charity's very first webinar. We've got some great speakers for you tonight, so I expect we'll all learn something new. We currently have about 100 people online, which is absolutely fantastic. So thank you to every one of you for joining us this evening. Please be assured that although you can see and hear the speakers, they can't see and hear you. So if you're on your sofa in your pajamas with a glass of wine, then please just sit back and relax. You do have the opportunity to speak or to ask questions during the webinar. To do this, just click on the Q&A button at the bottom of your screen. It should be somewhere near the middle, and type in your question. You can also upvote the most interesting questions by clicking the little thumb icon too. And we'll do our very best to get through the questions this evening. So we're going to start off our webinar tonight with Professor Joerg Steier. So he's Professor of Respiratory and Sleep Medicine at Guy's and St Thomas's NHS Trust in London. He's also Hope2Sleep medical advisor, and he's going to be giving us some insight into his role, particularly during COVID-19. So that's something I'm really interested to hear about. So Professor Steyer will talk for about 15 minutes or so. Unfortunately, Joerg is unable to join us for the entire webinar this evening, so we'll be doing a short Q&A after his talk. We'll then move on to Kath Hope, founder and CEO of Hope2Sleep, who'll be telling you all about the charity, who we are, what we do, and our plans for the future. So Kath will be talking for about 20 minutes, hopefully. Finally, we move on to Sam Backway. So Sam is a sleep specialist nurse at Great Western Hospital in Swindon, and she's also our Hope2Sleep chairman. So Sam will be providing lots of tips for achieving good sleep hygiene, as well as the importance of sleep compliance. So Sam will be talking for about 15 minutes. So we're going to end the webinar this evening with a Q&A session with Kath and Sam. We aim to be finished by 9:30 at the latest, depending on questions, and provided Kath keeps to her allotted slot. So without further ado, I'd like to pass you over to Professor Steyer.
Yes, thank you very much, Tim, for the very kind introduction, and thank you, Kath and team, for inviting me to speak here on this webinar. I hope you're all settled and after a long day in front of the still ongoing webinar function, able to follow. But I was quite pleased to be invited, because it's in these times where we virtually come together, of course, more important than ever to stay in touch with the patient, in touch with the great work that Hope2Sleep are doing, and supporting us in bringing together the patient with the professional doctors, of course. So my name is Joerg Steyer. I work at Guy's and St Thomas's, and I'm also Professor of Respiratory and Sleep Medicine at King's College London. In my role as a respiratory physician, this was, of course, a very challenging year. So typically my day, because Kath asked me to talk about a day in the life of myself, typically a day is very diverse, if you want so. When I'm on call, I work in a unit called the Lane Fox unit, which is a respiratory-led high dependency type of unit, where we see patients who wean from invasive ventilation or who require home mechanical ventilation. So patients may be on the severe end of the spectrum of sleep disorder breathing, patients who have respiratory failure, and not only necessarily milder forms of sleep apnea. So the Lane Fox unit was created 25 years ago, and was actually the sister unit of the sleep lab in Guy's and St Thomas's. The sleep lab was just next door, and at that time founded by Professor Adrian Williams, my predecessor. And so when I'm not on call, then I do what I like best, namely I work in the sleep lab. And this is obviously where many respiratory, but also in our case, a lot of non-respiratory cases of sleep disorders are treated. We are a fairly big sleep center. We have 13 consultants from all specialties, not only respiratory physicians, but also particularly neurologists, psychiatrists, psychologists. We have one neuropsychiatrist working with us. So we have quite a mixed team, a multidisciplinary team. And this is very helpful when it comes down to the treatment of any sleep disorder, because unfortunately, it is always the case that when you tick one box and have one disorder or one problem, you can also have another one. It's never impossible to miss out on things in medicine. So this is basically the rough job description, and my job therefore spans between very acute and maybe even critically ill patients down to the more GP-like scenario where I sit and analyze sleep studies with the patient and treat them for their sleep disorder. Now, the Lane Fox unit, as part of being critical care, and as the background is respiratory driven, was an important link this year in our ability, in our trust, to cope with COVID. Because you have respiratory physicians who are at the forefront of being not only exposed, but with the patient who comes with COVID, and try to manage them as much as they can. If they deteriorate, they are then, of course, further treated in the ICU, not only in the HDU, but they might require invasive mechanical ventilation, intubation. But similarly, as patients then come out of the ICU, as they improve and are weaning from mechanical ventilation, they come through our unit on the way out. And this is something that we were very proud of, that we have a very close relationship. I mentioned the multidisciplinary aspect of our team, also with the physiotherapists, with the occupational therapists, with the dietitian, with an outreach team to get patients home, enable them to get home again. This often requires, of course, the respiratory support. And the respiratory support, by that I mean they might go home with CPAP therapy, they might go home with a home mechanical ventilator, which is something like non-invasive ventilation, so a BiPAP mode, for example. So this is an incredibly important interface in these times, because as we ramp in and out of these waves of COVID, we needed to step up and down in our surge rota to accommodate the flow of patients. Our footprint in the ICU pretty much doubled during the first wave of the COVID pandemic compared to non-pandemic times. And although we are permanently trying to establish now a larger footprint with more capacity, more intensive care unit beds, units like ours that can easily take either role, namely that of a more outpatient-based approach, as well as a more urgent approach in the time of the pandemic, were incredibly valuable. We were the first unit that during the COVID wave in March, April was converted into a new COVID ICU when the critical care capacity in our trust did not accommodate the amount of patients that required this intensity of care. So we are still now in the second wave, trying to come to terms with the fluctuation of the demand. Whilst actually in March, April, Southeast London, where my hospitals are based, was the first and hardest hit area in the UK. Now in the second wave, this is very different, and particularly I feel with my colleagues and the patients, of course, further up north. Now in the second wave at the moment, places like Newcastle, Manchester and Liverpool seem to be the hardest hit regions, whilst here in London, and it is not entirely clear at the moment why that is, but here in London, the second wave, despite numbers being much higher than in the first case, our hospital admissions seem to be less severe, less overwhelming, and in numbers also lower. So in parts, this is of course down to factors like better identification of patients and better social distancing and other measures of health protection. But in parts, it remains unexplained why suddenly actually Southeast London had, even inside of London, the lowest infection rates compared to earlier in the year. And that raises the question whether there might be a degree of immunity, maybe in the general population who were extremely exposed to this wave. Anyway, we are still learning and we are still living and we are coming to terms with what is going on. So besides this kind of acute work, and we only got in the beginning of the week, again, the notification to prepare for the surge rota and convert our unit into an ICU support system. Despite all of this, there's plenty of other work going on. We are an academic health sciences center. We have plenty of students that we teach and try to continue to do so during the pandemic. We are having research projects that we are running. Some of them are currently on hold, others are continuing. And we try to educate everyone remotely these days. I'm sorry, but I do still appreciate the presence of people, so that actually after I finish here and hang up, I usually quite enjoy the personal discussion. This is all at the moment not possible for your safety and mine. But I very much hope in future, maybe in future meetings, this will be a real opportunity to have face-to-face discussions. Now, coming to the connection with the charity, and I was thinking about this in the preparation for tonight. I met Kath Hope in the sleep apnea awareness campaign, and that goes back to 2014. That was run by the British Lung Foundation at that time. We presented some of the results and outcome from that in the House of Parliament. And at that time, Kath Hope was the British Lung Foundation expert patient to advise them from a patient's perspective about sleep apnea. Now, she must have done her job extremely good, because she's still doing it more than ever with her own charity now, Hope2Sleep. And she was so good that actually, when I got to know her better, I asked her whether she could also help us with the expert patient at Guy's and St. Thomas's. So she picked up on this offer and she went through a course and she became our Guy's and St. Thomas's acknowledged and accredited expert patient for sleep apnea, which I really value, because ever since we have had many projects that we've put to her, that she has helped us with, and on which grounds we then sometimes got a grant to run a trial. And it is always patient focused work that not only our research group is doing, but that Kath helps us with. And this is incredibly important. Nowadays, these abbreviations, PPI, patient and public involvement, they get so lost anywhere on the paper. In the end, most of the work that our research group is doing is patient focused, because we're all physicians. I am not a basic scientist, I'm a physician. And therefore, most of the problems that I identify are served to me via discussions with the patient. We are doing work around CPAP therapy, non-CPAP therapy. We are trying to develop new methods of treating sleep apnea. We are trying to develop patient-based outcome parameters. And we are trying to look into what affects the quality of life. And for this purpose, an interface, someone, if you want, so on the ground, someone like Kath, someone who has a charity like Hope2Sleep behind them is incredibly important. So I don't want to stretch my time, and I'm quite aware that I was given 15 minutes, and I see on my Q&A session there are questions coming up. So I think I've got exactly the 15 minutes, and to give everyone else the chance to either talk to me, put questions out, or just afterwards get rid of me and move on to the next point, I hand over back to Tim.
Thank you, Joerg. Thank you for your time this evening. It really is appreciated. So you've probably seen the questions coming through. We've had a few sent in beforehand. We do have to be careful about providing medical advice in a sort of public setting, but we'll do our best. If I do some of the ones which were submitted beforehand first. So we have one that says, if you're on therapy and if you wake up in the morning with a stomach full of air, which is quite painful, and you need to go to the toilet straight away, what could be causing this?
Thank you. So what you describe is a phenomena that the medical slogan would label aerophagia, yeah, that you swallow some air at night. We all do occasionally, most typically when we eat and drink, and then you just relieve the air by having a small burp and relieve the pressure, yeah. So at night this can happen when the CPAP pressures are high. The food pipe has a certain pressure with which it occludes. And when the CPAP pressure is higher than this occlusion pressure, then the CPAP occasionally, with every breath that you take, might actually inflate a little bit of air into the food pipe, and you swallow it, and it leads at the end of the night to a significant amount of air in your tummy. Now, the best way to get around this is, of course, do the natural function and relieve the pressure, as I described. It's not something that is dangerous typically, but inconvenient. If it's happening extensively and causes pain, cramps, spasm, then you should talk with your doctors who treat you with CPAP therapy, because it might be that you are, for example, as we used to have everywhere in the UK, you might have a fixed pressure CPAP device, and fixed pressure CPAP means you get all night long one pressure, that pressure that controls ideally all your breath holding events. But for large parts of the night, these pressures might not necessarily need to be that high. There is nowadays a device that's called the AutoSet CPAP, and that measures permanently the airway resistance and adjusts the pressure at night. When you're lying on your back and you're in a very relaxed state and you have a high occlusion with a high pressure, then it ramps up the pressure. But when you're sleeping on the side in other sleep stages, you're more relaxed, you might actually need just a lower pressure, and it adjusts to that, so that you most of the night have maybe a lower pressure than what would be a fixed pressure CPAP that you have. So in turn, that means if you have an AutoSet machine, this might help you to have over the night lower CPAP pressures, which could avoid that you inflate the stomach, and which would avoid, therefore, that you have a big bubble of air in your stomach when you wake up. So that would be something to maybe discuss with your local center who treats you. That you have an urge to go to the toilet in the morning after a night of sleep is normal, out of many reasons. But if you have high pressures in your tummy, the abdominal cavity is linked, just like the chest cavity is linked. And if you have high pressures in the top part of the tummy, it will also push on the bladder. So if the bladder is full, even more so than if the tummy would be empty of air, you will feel the urge to go to the toilet, and it will be quite uncomfortable. Yeah. So by reducing this aerophagia problem, you will probably also not have such an urge to go to the toilet in the morning. That you go to the toilet in the morning is relatively normal, though. And also nocturia, just in general terms, can always be a sign of uncontrolled sleep apnea. So always make sure that you speak with your center to reassure yourself and them that they maybe check with a pulse oximeter also that your sleep apnea at nighttime is currently well controlled with the treatment that you have.
Wow, thank you. Looking at one of the most high voted questions, can CPAP cause fluid retention in joints, for example, ankles, knees and hands?
Not to my knowledge, no.
There we go. Once you're on CPAP and compliant, how does the condition progress with age? That one had a couple of votes.
Yes, so first of all, sleep apnea develops because your upper airway becomes collapsible. Typically, the collapsibility of the soft tissue is age dependent. So in children, you've got very, very soft tissue, which keeps its shape. But as you become a teenager, you might start to snore. In your 20s, you might actually start to occlude. And then as you age, look at my forehead, yeah, the connective tissue loses its elasticity. You develop wrinkles on the outside, but the inside of your airway, which is a soft tissue tube, becomes more collapsible. So typically you see sleep apnea more affecting someone who is not just gone through the teenager years. So as you age, we know this from a study that Mary Morell had done years ago at the Brompton. We find quite a high prevalence rate of sleep apnea in the elderly, so beyond the retirement age even. And therefore, one would expect that if you have sleep apnea in theory, this can deteriorate over time. However, there are other modifiable factors, and the most important one, presumably body mass. Yeah. So if you have a large neck and you're overweight or obese, that means this load that pushes on your upper airway can be modified. So you might age, but if you're overweight and you lose in weight, sleep apnea might still improve. So I wouldn't be just pragmatic and say, oh, I'm aging, it's going to deteriorate in any way. That might not necessarily be the case. If you are overweight or obese, which unfortunately in the UK, our population, we know we have a problem with that, and you slim down, we do know from studies that actually if you lose more than 10% in your body weight, if you are overweight or obese, then you can improve sleep apnea severity dramatically. In the most extreme cases, you might actually reverse this and lose sleep apnea. Think of bariatric surgery where you lose within a year 30, 40, 50% in your body weight. We do know that sleep disorder breathing, even severe sleep disorder breathing with hypercapnia, so hypoventilation syndrome, in addition to sleep apnea, might be reversed. You might normalize your breathing at night. So I would expect, if nothing else changes and you age, you have sleep apnea now, it might slightly deteriorate over time, yes, but there are other factors that might be modifiable and that might mean this is not automatically the case.
Great, thank you. Lots of questions coming in, trying to keep up with them.
Good.
I'm sure, hopefully you can see them too. If there's any you want to have a look at.
Yeah. Hello, do lots of OSA patients have esophagitis? Thank you. I would say esophagitis promoted by reflux, gastroesophageal reflux, yes. Why? Because you typically develop, when you obstruct, very high pressures to try to breathe in with a high negative pressure in your pharyngeal space, which means you might suck up acid into your food pipe and have nocturnal reflux, and that can cause esophagitis. So yes, particularly untreated OSA might often have esophagitis, or even worse problems with heartburn, or chronic changes on the mucosa. That's why actually treating sleep apnea could often improve this drastically. So CPAP therapy certainly helps with that in the long term. Can sleep apnea go away with latent weight loss? Yes, I answered that. It can. If you're significantly overweight or obese, and you lose in weight? Yes, it can. I only had patients today who told me that they had lost in weight, and all the snoring, all the breath holding that the partner experienced had just vanished. And we studied them, and they didn't have sleep apnea. So yes, we do know this. As I pointed out, this can significantly improve the condition, sometimes completely offset the condition. Other advice related to that: posture. Typically, sleep apnea is worst when you're sleeping on your back. So sleeping in lateral posture or prone, even if you prefer, is often something that is helpful. Why? Because gravity, when you're on your back, pulls the tongue ground backwards, whilst if you're on the side, it pulls it away from the upper airway. And therefore, posture is also something to consider. Food-wise, particularly to mention alcohol. Alcohol is centrally relaxing. That's why we like it. Or those of us who drink it like it. And that effect is also an effect that is on the muscles, relevant in that the muscles will be more relaxed, and therefore this becomes more collapsible. We may all have experienced this. If we have a pint or so at a pub on a Friday night, then we all snore. Our partner tells us so, yeah, the elbow sign. So, and the same is true when you have sleep apnea. Typically with alcohol, this gets worse. Without alcohol, it gets slightly better.
Somewhat linked to that, there's top one. Are there any exercises or effective alternatives to CPAP?
So exercises, there's something called myofunctional therapy. We are trying to work out whether it works. You might have heard of the didgeridoo study, yeah? But alternatives, yes, evidence-based mandibular advancement devices, something that looks like a gum shield that advances the lower jaw whilst you sleep and stretches the airway open. There's evidence it works. It works particularly in mild, less so in moderate, and not so good in severe sleep apnea. NICE, the National Institute for Clinical Excellence, recommends mandibular advancement devices for the use in mild and moderate sleep apnea. So yes, that is a true alternative. Other alternatives, it depends. If you have a significant abnormal upper airway anatomy, like enlarged tonsils, adenoids, polyps, then an ENT review and a correction of the abnormal anatomy might help. But there's very little evidence that actually on a normal airway surgery will help. Thus, we actually moved away from what was happening in the 90s and in the early millennium, operating on everyone, because it has side effects, it is not risky, and if it doesn't cure the problem, why would you do it? So in addition to that, there are experimental ways to try to treat sleep apnea. We are testing electrical stimulation at Guy's and St. Thomas's, and hopefully we'll hear more about this over the next year or so. We're trying to use a non-invasive stimulator to treat sleep apnea, to keep the muscles that otherwise relax and then make the airway collapsible in shape. We try to activate them whilst you're asleep so that the airway doesn't collapse. There are invasive pacemakers that are now provided, and hopefully over the next year, we were due to do this year, but with the pandemic, we were not going forward because elective surgery was stopped in March and so on. So we haven't found track with that yet. So, but this is called hypoglossal nerve stimulation, and that's at the moment still more in the experimental phase. Myofunctional therapy, so the training of the upper airway muscles, there might be something in it. The didgeridoo study that I mentioned showed that if you do permanently strong exercise with your tongue ground muscles by daytime, then there might be an effect on snoring, possibly on sleep apnea over the long term. But whether it cures it entirely and whether we all find the time to do that kind of exercise, I wonder, because it is more than a strenuous exercise. And if we all did that, then I would expect that typically the whole population could be slim again. Yeah, so that's something where we need to be realistic with our expectation. These kind of therapy proposals often sound fantastic. Whether they're realistic is a different matter.
Cool. Very conscious of your time, so if I ask one more question, maybe.
Okay.
Do you have any recommendations regarding upper airway resistance syndrome? I'm 11 months into CPAP therapy and I'm seeing no benefit.
Yes, upper airway resistance syndrome for everyone. This is when you have the narrowing of the airway and you breathe harder and harder against that resistance, but airflow continues. You do not have apneas. You do not desaturate necessarily, but you do wake up because of the work of breathing against that resistance. And that sleep fragmentation will still lead to a bad sleep quality and to daytime symptoms, not unlike in obstructive sleep apnea as well. So the upper airway resistance syndrome, well, first of all, one needs to question, how was it diagnosed? Was it correctly diagnosed? Second, if it is completely treated and accurately treated and your breathing is normal, but you do have the residual symptoms, meaning most likely something like excessive daytime sleepiness, then you can have different conditions. That's what I meant earlier on. You can always have one and the other. Yeah, it's not that you, unfortunately, because you tick the box upper airway resistance syndrome, are not prone to have other conditions that can leave you also excessively sleepy, fatigued, worn out with all the symptoms. So typically what we would recommend is go and talk to your center that treats you. Make sure the upper airway resistance syndrome is accurately and correctly treated and there's no further respiratory effort related arousal from sleep. That would be maybe just to compare it to the apnea-hypopnea index, yeah, because the RARAS, respiratory effort related arousals, is what wakes you up in the upper airway resistance syndrome. Second, have your bloods checked. Thyroid function, anemia, iron levels, the typical problems in the general population. I'm not saying this is the problem here, but it's worth checking because it's very common that something might not be quite right. And low iron levels, even without an anemia, might explain why one is still fatigued, worn out, sleepy. Then there are, of course, other conditions that can contribute. Unfortunately, something even like depression, again, fairly common, or post-viral fatigue in this year with the pandemic, again, very common, can really present themselves as something that looks very similar to untreated sleep apnea or untreated upper airway resistance syndrome. So if the condition that you have, that you think is attributed to the symptoms, is treated correctly, but you still have the symptom, go back to the doctors and tell them they need to figure out why you have the symptoms. It might not have been the cause, yeah, that the upper airway resistance syndrome was causing your problems.
Great, thank you very much. So many questions coming in. We do have a Q&A session with Kath and Sam at the end, and I can see Sam is frantically typing answers to questions too, so you may get a personal response from Sam. Thank you so much for your time, Professor Steyer. It's been fantastic having you, and we look forward to speaking to you again soon.
Thanks ever so much, Joerg. Thank you.
Thank you all so much. And I take the questions that are coming in as a sign that something that you Hope2Sleep are doing is quite right. Yeah, there's obviously the need to answer a lot of questions, and that is a success. And I wish you all well. And thank you very much for having me.
Thank you.
Stay safe.
Thank you.
Thank you. So I'd now like to pass over to CEO and founder of Hope2Sleep, Kath Hope.
Am I on screen? Right.
You're on the screen. I think Natalie just going to share your PowerPoint.
Okay. Right. So, firstly, I'd obviously might not get a chance later because I'm not in charge of the mute and the unmute button. But I do want to say a quick but big thanks to Tim, because setting up online events like this and it being our first, you know, takes a lot of planning, and certainly working with me gives him cause for concern, as you can see in one of our private messages. Except Natalie ain't showing it. Right. Okay, Tim, do you recognise that? Yes.
It's still my number one concern today. I'm hovering over the mute button.
Yes. So, yeah, I do. I've got to say, sometimes when we are dealing, with things like research and they want something with 100 words, and I create 250 words, and I often send it to Tim to condense for me. So yeah, if I do mute, you know why. It's because I've gone over time. Because I can really speak for England when it comes to sleep apnea. In fact, when I did speak, as Professor Steyer mentioned, for the MPs in Parliament, I'd also been warned that I was on a time limit. But I actually did get a few MPs, John will back me up, saying that they would like to join their party because they could really do with people speaking with such passion. And behind my hand, no thanks. And there was some MPs there who did fall asleep during my talk, but I did tell myself and some of the other MPs who remained awake, it might not just be my boring speech, but because they actually had sleep apnea. Nodding off in places like theatre or talks is, a prime example, isn't it, as a lot of us know. So thanks again for joining us today on this first webinar. We do hope this is the first of many, seeing as COVID has prevented us from travel in the country, which we usually do, raising awareness and going to support events or setting up support events. So at least this way, we're able to meet with you from the comfort of your own armchairs. A lot of you already know, I'm sure, and I just, when people ask for a story, I think really it's quite boring now. It's been said, told hundreds of times. So very, very briefly, for those who don't know, I did get a shock diagnosis of severe sleep apnea, which was a long time ago, back in the days when a lot of people, even in the medical profession, thought that sleep apnea was only really aimed at men, overweight men as well. And very few people, there were some, but very few people of normal weight or underweight were diagnosed in those days. And I remember the sleep clinic taking one look at me and saying, well, you won't have it, but we will test you anyway. Well, they didn't say I won't. They said, we're sure you won't have it, but we will test you, because an ENT consultant at a routine appointment actually referred me. Well, thank goodness they did. It was only after my own diagnosis as well. And I remember my dad, when I told all the family, and he asked what sleep apnea actually was. And it was only after talking and discussing that we realised that my poor mum had also been suffering from it. All her life, she'd battled weight problems, yo-yo dieting constantly, mental health, unfortunately, high blood pressure she had, acid reflux, insomnia, all the classic signs that we know about now, but obviously hindsight's very good, isn't it? And sadly, the first heart attack she did have when she was age 49 gave her no second chance. If she'd have survived and found out she had sleep apnea, I can promise you she'd have been by my side, because that's the kind of person she was. But we didn't get that second chance. And I was determined that my children weren't going to be robbed of their mum so early. Now, back then, we did have a wait. I think NICE had only just, if they even had, actually said in their guidelines that people had to be issued with CPAP. Many years before this, if people did have sleep apnea, they had to fund it themselves, or they had to go through surgery, which they often were told would cure them, had cured them, only to find out later it didn't in all cases. So anyway, I was really looking forward. I'd gone on the internet and all these people's lives had changed. And I was just dying for that. So I finally got it 5 months later and I couldn't wait. However, that's where the problem started. I wasn't one of those lucky people. Some people are, most aren't. That first night is like a duck to water. Unfortunately, you know, that's not the reality. But the reality is, if you stick with it, and you do, you know, most people, especially who come our way, do stick with their therapy, especially when they know the consequences of untreated sleep apnea. And for those who don't, please look at the website, on our website, what is sleep apnea? There's a whole list there, and I'm on a deadline here. And I've had no funny looks from Tim yet, so I think I'm doing all right. So yeah, joking apart, you know, I did have problems. In fact, I remember, you know, all the mask noises, shall we say, that I thought, what are those neighbours going to think? You know, they're really going to think I've got problems, you know, flatulence problems, as these loud noises would go all through the night, as I would rip the mask off my face and chuck it across the bedroom. And I don't swear a lot, actually, and that is true, but I did those nights as the mask went flying through the bedrooms, because really, back then, they weren't made for the normal person. I don't say made normal person, we're all normal, aren't we? I mean, people who weren't overweight, they were aiming the mask, really, back then, at the bigger man, you know, with obviously a bigger neck and everything, and the headgear I used to have to literally sometimes wrap around twice. You know, so I went from one problem to another, and there was no support. That was the worst of it. And I'm very, very grateful, and I'm sure there's a few of you listening tonight, to all those friends in the USA, all those people, all those friends I made and are still friends today, and supporting our UK charity, who helped me back then, giving me lots of tips, telling me about these comfort products that weren't even in the UK. My clinic did help. You know, they must have given me about 10 masks, but I'm afraid, you know, I just struggled so bad. Fortunately, today there's a lot better masks out there, as Samantha will tell you. You know, at the clinic, there's, you know, it's not a case of just handing one off the shelf. You look at the person, their facial profile, try and give them the better masks. Ask, you know, are they mouth breathing? Are they nose breathing? All that makes such a huge difference. But the fact that there's such a lot of choice, you know. So anyway, so really, I started to get, you know, some of these comfort products from the USA, because there wasn't any in the UK at all. I often used to have to pay extra duty, a lot of duty. I remember one man from FedEx, he wouldn't leave the door till I'd given him a check, and I couldn't find my checkbook because then they used to take it off you at the door. Anyway, I'm digressing now. But not just the, you know, the lack of the comfort products, but it was the support. And I never wanted anyone to feel like I did, because believe me, I was frightened. By that time, I knew that sleep apnea had robbed my mum, you know, from us early. And Alex particularly was only a young boy. And he's actually listening tonight as an adult, but he was a young boy back then, and he was terrified, you know, when he overheard the conversation that his mum was stopping breathing 32 times an hour. That was a mistake. So, you know, this was why Hope2Sleep started, because if I can help somebody, I will. So I do have to mention, because I know I'll get into trouble later, and I've seen Katie Atkins' name on that list, and she's my daughter. And she will say, and I get in trouble often when I come off the radio or whatever, so you never mention me. Right, I'm going to, Katie, if you're listening there. 5 years before I got diagnosed, Katie shouted from her bedroom, "Mum, you've got sleep apnea." Did I listen? Of course I didn't. Do we listen to our families? She was, if I remember rightly, it was just before she went into a nurse training, or when she was considering a career in nursing, which she is now, by the way. And I thought, you know, she was reading all sorts on the internet. I thought, what wacky thing is she reading now? And totally didn't listen. That's sad, really, because with sleep apnea, it's actually usually other people that do notice, isn't it? You know, what's happening in our sleep. And so that was a learning curve, don't worry. And, you know, do listen to, you know, especially your bed partner, if they're aware that you're holding your breath, that they're having to nudge you, you know, please, please, you know, it's not just about snoring this, it's about stopping breathing, which is detrimental to your health. Most of you today will be aware of what, you know, sleep apnea is. And there is, like I've said, more information on our website. But Samantha, our chairman, who's speaking next, he obviously will educate you briefly about that. And you know that you can contact us anytime. So the charity team. So 2009. When John and I started Hope2Sleep, that was with the support of my whole family. It was hard going as well. We had to continue teaching 85 pupils a week. How on earth I did that and this, I'll never know. At the same time, I was trying to support all these people while, you know, keeping up my, you know, paid job. And it got to the stage as well that our house was totally overrun by products. It got so bad in the end, we were actually up the stairs, you know, all the way, you know, on the stairs themselves, I mean, quite a trip hazard. You know, so, but these products were very, very important, very crucial for a lot of us. John, he used to do the orders from the spare bedroom. Before he went to work, he would get up at the crack of dawn and he would do these orders, get them all ready, take them to the post on his way to work at the railway. Or if he was on an early shift, he would come straight home, straight up into that bedroom and continue the orders after his shift had ended. I was the one who was dealing with support and he was, like I say, fulfilling orders. So in 2016, we finally got established. When I say finally, it was just the fact that we were so busy. You know, it was the fact that Tim, you've just put me off. he's putting his hands up.
Sorry, Kath. 10 minutes.
All right, I won't look at you anymore. Yeah. So, what was it? Where was I up to? Thanks, Tim. Yes. So it was the time. It was the time because you know, I was teaching as well, working all hours, and it was having the time, you know, to get set up as the charity. But thankfully, you know, fantastic people came along and helped with that. People with the same passion as me, obviously, people who are still with us today. And in 2017, we finally were able to move into the charity premises. Excuse the amateur photograph because I know you can see me taking the photograph in the reflection. It's a hard to take a photograph of the actual shop. One day we'll have it done. So that's our charity shop, charity premises, where, you know, obviously the sales are done from there, but support as well. People come through our door all day when COVID isn't around. So if you can catch just the first few words, if you listen carefully to our Lord Mayor.
Don't think the sound's coming through, Kath.
Yeah. I'm not sure if you heard that, but what it was our Lord Mayor who we'd invited to come and open the charity. What we didn't know when we asked him and why he was so eager was because he had sleep apnea, unbeknown to us, and he'd actually had it for 20 to 32 years. Although he was quite cross that he'd never heard of the charity on his own doorstep here in Hull, but he knows about us now. So, yeah. So, right, slide 6. Right. So, so obviously, I'm just going to try and quickly introduce the staff first, which obviously is me. There's me sat there. Now you can see behind me is the bed. The bed's in my office. This is where people come from all over the UK to lay on that bed and try on masks. If people who are struggling, they can try on 20 or 30 masks if it comes to it with their own machine. So then we've got John, my husband, who is the office manager, which he always has been really before receiving a charity. He did take early retirement anyway from the railway to continue working for the charity. And he does the bulk of the orders that so many thank us for getting so speedily. And then we've got Natalie. Now, I know you can't see Natalie, but she's on my right-hand side doing these slides, ready to nudge me and let me know where I am if I go off track. She really does have her job cut out organising me, bless her. And a lot of you have already spoken to Natalie on the phone anyway. And then we've got Kirsty, and you can see we've got the before and afters. Unfortunately, this is pre-COVID, and this is at the moment. The charity isn't open to the public at the moment. We're in a very high area here in Hull. But John is still there doing the orders, and a few of us pop in from time to time, but we're still doing all the work that we did before. So no charity can run without volunteers, obviously. And I have to give a huge special thanks to Paul at the top there. He's a qualified accountant, and he works every day and often several hours for the charity as a volunteer, ensuring all our accounts are in order, and also the huge job of sending our accounts to the Charities Commission. Martin at the bottom there is always on hand when we run into IT problems, like I did today, but that's another story, and he doesn't even know it yet. We obviously we have a lot of volunteers, at different places where we go throughout the UK. But June is our local one, and June's always with us, and that's her at the Bransholme Shopping Centre, where we went to raise awareness, and the GP's surgeries were overflowing after we'd done that. I don't know whether they were pleased with us or not, but there was a lot of people asking for sleep clinic referrals after meeting us that day. So, but a big thanks to all of our trustees all our volunteers who are not named, but are always eager to help us when we do a shout out that we might be in their area. So obviously moving on to the trustees, because with this being our first webinar, I just wanted to introduce us properly. I do have to mention our first chairman, which was Wendy Douglas. A lot of you may know from the Raigmore Sleep and Ventilation Clinic. She was our first chair, who we were lucky to have, and just as fortunate as that, we now have our lovely Samantha Backway. A lot of you already know. I won't be surprised if half our patients are here. Everybody loves Sam. She does everything she can to help people. And she is in our Facebook support group as well, every day, over and above. The call of duties definitely is our Sam. You've already met Tim. And you can actually see he's a bit of a taskmaster because he's watching me now. And I dare look up in case I've gone over hours. I'm only kidding, Tim. We have a great relationship. I've known 10 years. Yeah, we're really grateful to him for tonight, which I've already said. We've got Karen there in the middle, who's our treasurer. She often emails people. A lot of you will have spoke to Karen via email. And in the Facebook group as well, probably. She works also very hard, with us wherever she can. She'll pop in if we need cover at the office. So that Karen's another gem. And Caroline, a lot of you'll know Caroline. 3 out of 4 of her children have sleep apnea, so she has a wealth of knowledge and experience of children's issues. And she works very hard in the background on the Facebook group, which is now, whoa, over 7,000 members, I think we've got. You know, but we're very strict who does come in, and Caroline has that hard job, making sure people are genuine, and obviously supporting in the group as well. We're very, very fortunate to have such well-respected medical advisors. Professor Steyer, who you've already met and kindly spoke. We've got Professor Heather Elphick for the paediatrics, and Dr. Ari Manuel, and you will be meeting them on future webinars, because they both said they'd love to attend. And last but not least is our patron, Dom Jolly, who should need no introduction. And hopefully you'll meet him in the future too, with his own sleep apnea story. Now, it goes without saying what we continuously do, which most of you already know. Our priorities always will be in raising awareness of sleep apnea and helping people, signposting them to getting diagnosed and treated. And obviously it doesn't stop there, because they then have free support right throughout, you know, once they get the CPAP, and existing people come our way all the time. We do, of course, as Professor Steyer did mention, help with research as well. A lot of the clinics as well, we support them. We go to their, help them support, actually, set up awareness events, or sometimes we'll just visit to back them up, to give them support, or sometimes they might have a problem with a patient, and it, you know, comfort issue, not medical issue, so we're always there for them. So this support, I've put a heading here for myself. This is the bulk of our work, and it gives us all great pleasure to help people sleep safe and more comfortably. All support is always free, as most of you will already know. Everything we do is free, apart from the sales of the products. That is the only thing, you know, that we can't give free, because the sales are what funds the charity. Nobody needs to make a sale to get support from us, but obviously, you know, myself included, a lot of those products that we sell are actually needed to get that comfortable sleep. And I, for one, use liners every night, wipes every morning, hose lift every night. You know, there's, you know, and I couldn't manage CPAP without it either. So, we are very fortunate, especially in these trying times, that we can self-fund with the products that are helping so many people, because it is sad to read, you know, when other charities do struggle, you know, especially at a time like this. I'm not saying we're not struggling, but we're surviving, and that's the important thing. We're all in that together. In this pandemic, we're all wanting to survive, aren't we? So we did recently design a survey, of which many of you kindly took time to answer, and we were astounded by the results. I say this because I'm talking about support. These were people who we do support. We didn't just put it out for anyone, we put it in our groups, in our newsletter, and as you can see, almost 93% of people use their mask and machine for all sleeps wherever possible, and that is huge. It's I've made some notes myself here. 6.8% wear the mask often, and out of 567 people, only 2 said they don't use it. And we do hope those 2 will contact us, because, you know, every single person is important. Untreated sleep apnea, well, we all know the damage it can do. You can see on the next slide, you know, for yourselves, how long people use the therapy for, and almost 83% say that they use it all the time, and I'm one of those. We were also interested to hear of what comfort products help them. And it wasn't a surprise at all, actually, to see those top 5. The mask liners, the strap covers, the hose covers, the Xylee melts, that dry mouth problem that so many people have. And the cream, although it says nasal cream, it can be used anywhere, and the hose lift. As I was saying to Natalie earlier, if only the NHS could afford to issue the hose lift with all the machines, it would save so many problems from day one. That hose lift, and you can see that by the reviews on the website. So many people are saying what I'm saying right now. So I'm sure you all know of the ways we help via the charity's walk-in support centre, which I've already showed you. That's when COVID didn't come along and spoil things. Our Facebook page, the private group, and it is private if anyone wants to be in there. Nobody can see anything that's being said unless they're in the group. This is the private group as opposed to the Facebook page. We've got the charity helpline, which rings all day. We've got emails that flood in all day. The public forum, for those of you who don't like Facebook, used correctly, Facebook can be a wonderful tool there. Our newsletter, make sure you're on that, because that lets you know of not only the products but events like this and research as well, like Professor Steyer was talking about. We also never miss an opportunity when invited by the press, so that we can get out there and raise awareness. We have so many future ambitions, but I know that I'm running out of time now, Tim. So very quickly, how can you help us? Thanks first for many of you that already do. What do we want you to do? This isn't all about, money and things. This is about, please join us on social media, help us get that message across. Join the public page, share all the posts we put up, because every time they get shared, I can promise you somebody realizes they've got sleep apnea and gets diagnosed. And I know that for a fact because they come back to us and tell us. So with Twitter, LinkedIn, Instagram. In fact, we've even got Pinterest. Pinterest, we're even on Pinterest. And also, could you distribute our leaflets? A lot of the sleep clinics already ask us for the leaflets, and we send them in hundreds, and they display them in the clinics, and a lot of them give them out. But if you know of a clinic that would like you to take some in, or any other event that you hold in, just contact us and we can get them out to you. Please direct people to us. They may only buy a £10 one-off product, never need to buy again, but once they buy from us, it's the fact that they found this support, this lifetime support, even if they never buy another thing again. So fundraising's difficult at the moment. That's unless you want to do anything like that wonderful Captain Mo, was it? Feel free to get some walking around your garden and fundraisers. That would be really helpful. And the donations, thank you that they are actually still coming in, and it helps us. Even for just events like this, people don't realise, I think it was £300 just to get this Zoom going. Nothing's for nothing, unfortunately, these days. So I am going to have to wind up now. I do want to thank you for joining us, and I also want to thank you for all the support you give us too. Thank you.
Thank you, Kath. So only 4 minutes over. Very good.
Wow, that's good. That's
Excellent.
good for me.
Before I pass over to Sam, I saw a question from Irene, which I guess I'd like to address because it's related to what you've just been talking about, and it's around how a lot of the support events have been in sort of the Midlands and more towards the north of the UK, and she's based in the southeast. I'm based in Portsmouth, so you don't get much more south than me. But just to say that it's obviously not a dream, but a plan of the charities to do a countrywide tour when both COVID and also finances allow. So I just wanted to, rather than type an answer, share that one verbally, that a national tour is on the cards as soon as it can be.
Yes, definitely.
I'd now like to pass over to Sam.
Right, well, thank you, Kath, for that brilliant introduction of your charity. I never get tired of hearing Kath talk about her story and her wonderful work that she does in the Hope2Sleep Charity. And I'm so pleased and privileged to be part of your inspirational team, Kath. You are amazing. I first met Kath about, God, 6-7 years ago. And I was looking online for some support for my own patients because I couldn't really offer them much. And up popped Kath, and there's another story, and we ended up being firm friends ever since, haven't we? So absolutely amazing. So I've been asked really to sort of talk to you about how to achieve good sleep hygiene and your therapy. Now, 15 minutes is not long enough to talk about it in great detail, so it's only going to be a real snapshot, I'm afraid. I mean, each of these subjects is a talk on its own, but basically, why do we need sleep, obviously, is the first question. So sleep is an essential bodily function. It allows the body and mind to recharge, leaving you refreshed when you wake up. And it helps your body remain healthy. It improves your immunity, which obviously at the moment with COVID-19 and the flu season coming in, it's very important that we get our proper sleep. Regular poor sleep puts us at risk of serious medical conditions, and obviously this can shorten our life expectancy. And sleep is essential for a long and healthy life. So without the sleep, brain cannot function properly. So sleep hygiene. Paying attention to your sleep hygiene is one of the most straightforward ways that you can set yourself up for better sleep. It's about putting yourself in a better position to sleep well each night. And it involves both your environment and your habits during the day and at night. So here's just some very, very quick tips to try and help you with your sleep hygiene. You can adapt these to fit your circumstances. They're obviously not going to fit everybody, and everybody is an individual, so just keep trying them. So basically, the first one, set your sleep schedule. This will normalize your sleep as an essential part of your day, and it will help your body get used to the full amount of sleep that you need. Have a fixed wake-up time, whether it's a weekday or a weekend, and try to wake up at the same time every morning to help with a consistent sleep. Make your sleep a priority. It might be tempting to skip sleep in order to prioritize your work, study, exercise, etc. But it's really important to prioritize your sleep. Calculate a target bedtime based on your wake time and try your hardest to be ready for bed around each time that night. And Kath, this does mean you. She is the worst one in the world for this. So Kath, this is for you too, for all of us. You'll need to make gradual adjustments, though, if you want to shift your sleep times, but don't do it all in one night, because obviously you need to settle into a new routine. You're not going to be able to do it. It might take weeks or even months to change your sleep schedule. So more tips as well. Try and keep naps short. Naps are a great way to regain energy during the day, but obviously they can stop you sleeping at night. So keep them short and limit them really to the early afternoon. And I would say roughly 30 minutes to 45 minutes maximum. I wouldn't go any further than that. Follow a nightly routine. How you prepare for bed can determine how easily you fall asleep. And following the same steps each night is great, because just something as simple as putting on your pajamas and brushing your teeth can reinforce your mind it's bedtime. Unplug your electronics. This is really, really important. Around 30 to 60 minutes before your bedtime, turn them all off. Mobile phones, laptops, TVs, etc. They cause mental stimulation, and this can generate a blue light that may decrease your melatonin production. Dim your lights as well. Keep away from bright lights during the sort of end of the evening. Put your lamp on, turn your main lights off, because these can hinder the production of the melatonin. And melatonin is a hormone that your body creates to facilitate sleep. So if you're hindering that production of that hormone, you're not going to get that trigger to fall asleep and be sleepy. And don't toss and turn. There's no point lying in bed. Your mind needs a healthy connection between being in bed and going to sleep. So, you know, if you're in bed and you've been tossing and turning for 20 minutes and you haven't managed to go to sleep, get up and do something a bit more calming in a low light. And I don't mean sitting on your mobile phone or watching the TV. just sit quietly with a book, or even just listening to some very, very light music on your iPod or something like that. Nothing too stimulating. So again, we need to do some healthy habits during the day. It's not just nighttime habits that are going to play an important part in your sleep. You also need routines during the day. So you need to get some daylight. Very important to get some daylight. Get some exercise. Don't smoke. Nicotine is a stimulant, and obviously that can disrupt your sleep and wake you up during the night. Reduce your alcohol consumption. Alcohol may help you fall asleep quick, but it does wear off pretty quickly, and then that will cause sleep disruption later on in the night. So if you can try and avoid it in the evening, easier said than done. We all like a night out, and obviously the odd one is not going to make a difference, but try not to have a regular consumption. And also cut down on your caffeine in the afternoon and evening. Again, caffeine is a stimulant. It's very quickly absorbed into the body, and it's great for keeping us awake and keeping us stimulated, but the effect can last many hours. So really, after sort of early afternoon, you shouldn't be having any caffeine, and do be careful about foods and medication that contain caffeine as well. There's a lot of caffeine hidden in various food substances, so be careful to watch that as well. And also you need to make your environment sleep friendly. So make your bedroom sleep friendly. So your environment is just as important as your sleep habits. There's no point working on your sleep habits and then your environment is not very good. So you need to make your bedroom calm and free of interruptions. Have a comfortable mattress and pillow. And obviously your sheets and bedding should match your needs as well. So whatever you prefer, if you like silk sheets, that's fine, or you want your flannelette, get them on, but it should match your needs. Have your bedroom temperature to suit your needs as well, but ideally it needs to be on the cooler side, and we would normally say sort of between 18 and 24 degrees centigrade. Block out any light, use heavy curtains or an eye mask. Drown out any noise. Obviously some people might need to wear earplugs, etc. Now the concept of your habits and environment, that should be optimized. Yes, sleep does apply to everyone, but this can vary between individuals. Not everything is going to work for everyone, but it's worth testing these out and adjust to what works for you, and don't try everything at once, because obviously it won't work and you won't know what's worked best for you if you've tried them all. Sleep hygiene is beneficial, but obviously there are still people out there that have got other sleep disorders that would obviously need other treatments as well. But sleep hygiene is just a part of all that for you. So obstructive sleep apnea, why we believe it's important to treat. So sleep apnea happens when you fall asleep, all your muscles in your body relax, including your throat and your tongue. This causes the throat to narrow and collapse. You're then not getting enough air into your lungs. You've stopped breathing. The effort of you then trying to breathe, because you're breathing against a closed airway, effectively arouses you. It wakes you up. You then wake up. You might wake up with a gasp or a snort, but you're awake. But then as you fall back asleep again, this process starts happening time and time again. And some people do this up to 100 times a night, and obviously that's very, very disruptive to your sleep. So you get nighttime symptoms and you get daytime symptoms. So nighttime symptoms, snoring. I think snoring is probably the most prominent symptom that we tend to hear about, and it's the one that you drag your husband to the doctor about because he's snoring and he's keeping you awake, and it really is very loud, distinctive snoring. And then obviously this stops when you stop breathing, so you get this pattern of snoring, stopping breathing, snoring, and it really is quite frightening to listen to. My own husband suffers with sleep apnea, and obviously I've witnessed this happen in various stages of his treatment, but also with my own patients. Choking and gasping, like I said, you might wake up choking or gasping, and it's something that you might be aware of. You might not be aware of the snoring, and you might not be aware that you're stopping breathing, but generally most people wake up with their heart racing and they're choking or gasping. Another one that's really quite important is restless sleep. So if your partner says actually you're moving around a lot at night, And this is because you're constantly being woken up because you're stopping breathing. So you're ending up moving around and getting quite restless. Frequent trips to the bathroom, obviously, that's something that happens quite a lot with people with sleep apnea untreated, and it is a symptom on its own. Now, daytime symptoms include feeling sleepy or falling asleep during normal activities. So obviously this little lad's fallen asleep over his breakfast, but you get people who fall asleep at their desk during meetings, in a doctor's surgery. I've had a few patients who've been coming on the bus and missed their stop because they've fallen asleep on the bus. So it's during normal activities that normally you might fall asleep. Waking up sleepy or unrefreshed. And I think I've met quite a few people who look like this. Kath looked like that about half an hour ago before she put her hair on, didn't you, Kath? Morning headaches. A lot of people complain about morning headaches, and it's not everybody suffers with it, but they do disappear quite quickly when you're awake, but it's a significant symptom. Difficulty concentrating, you know, you've got these fuzzy thoughts, you're losing your train of thought, forgetfulness, your difficulty focusing on what you're doing. Poor memory is another one. A lot of patients, I've had patients who've forgotten their appointment, or they've come on the wrong day, or they've come 2 hours early, they've forgotten the time. So yeah, poor memory is a very significant symptom. Irritability and mood changes. Now, along with the snoring and the stopping breathing, etc., this is it can cause problems in a relationship or a marriage if this is constantly happening. And sometimes you just don't know why it's happening and get diagnosed, and these will all go away. And loss of sex drive as well, that's an important one. So what are the consequences of having untreated sleep apnea? There's a lot more than this, and like I said, we could go into a lot more detail if we had more time, but these are probably the main ones. So you get cardiac problems, so you're increased chances of having a heart attack, heart arrhythmias like atrial fibrillation, risk of strokes. You get this increased insulin resistance, which obviously leads to type 2 diabetes, sexual problems, weight gain, anxiety and depression, high blood pressure, obviously cardiac problems, and also because you're so tired and sleepy, road traffic accidents. There's an increased risk of you having an accident on the road and also in the workplace if you're not concentrating on what you're doing. And then, like I've already mentioned, memory problems. So why is it important to use your CPAP or your therapy? So we want to effectively treat your obstructive sleep apnea. Nightly use will prevent future health issues that obviously can cause these problems, and to prevent daytime tiredness. And obstructive sleep apnea causes disturbed sleep. It improves your memory. It reduces stress and it makes you less irritable, which obviously makes your partner less irritable as well. And it improves your quality of life. And like I've mentioned, it stops you snoring, so your bed partner can sleep well too. So it doesn't just treat you, it treats your partner and your family. So one of the main questions I've been asked over the last few months is, should I still be using my CPAP during this COVID outbreak? So are you more at risk of catching COVID? There is no evidence to say that anyone who has obstructive sleep apnea has an increased risk of catching COVID-19. However, many patients with obstructive sleep apnea do have other long-term health conditions, diabetes, obesity, high blood pressure, and these are the risk of catching COVID-19, but OSA on its own does not increase your chances of catching it. But studies have shown that patients with OSA who were hospitalised with COVID-19 did actually need a bit more specialist care whilst they were in hospital. So they might need more oxygen, they might need the CPAP, and even go on to be ventilated. And most of these actually were ones with the other health conditions. It wasn't just obstructive sleep apnea on its own. So what we would recommend, so obviously using your CPAP does improve your long-term cardiovascular outcomes in all our patients. So as well as improving your sleep quality and your daytime alertness, we do recommend that you're compliant with your CPAP therapy. Sleeping well does improve your immunity, and research has proven that. So improve your sleep hygiene, use your CPAP, and ensure you're getting the sleep that you need. And as with everybody else, please take all the precautions to reduce your risk. So obviously, as well as washing your hands, wearing your face mask in public places, and keeping your 2-meter distance, and using your CPAP and sleeping well. Thank you. Keep calm and trust your CPAP.
Thank you, Sam. Important information for all of us as we all look at our screens, emitting lots of blue light. Let's see if we can take you off, remove spotlight. There we go. So, gallery view. So we have 10 minutes left. We've got quite a few questions, so let's go for a quick fire round. You should be able to see the Q&A on your screens too. So I'll read some out, but if you want to jump in with some, then please feel free to. Maybe if I do one or two which were sent in before the event first. So we've got one. Is it normal for the water tanks of the humidifier to be full one day and then either a little water left or none at all the next day?
Yes, that is quite normal. It really does depend on your therapy, how much pressure you're on, how many hours you've used your therapy for, and also if you're getting a lot of leak. If you're getting a lot of leak on your mask, you will use more water because you're breathing heavily through the chamber. So yeah, it is quite normal for it to fluctuate. And also the temperature changes in your bedroom. Your heating might be different. You might have it on thermostat, and as it gets colder it will turn on. So yeah, lots of things can affect it.
Cool. One for you, Kath. When I put my mask on, sometimes it feels like I might suffocate when I'm trying to start my breathing off and adapt to being on the machine. Sometimes it ends up with me putting my mask off in frustration if I can't fall asleep within 20 minutes. Do you have any advice to overcome the anxiety of this, and any practical advice?
Well, one of the things we've observed at the charity especially, is that, some people do have daytime panic attacks or a bit of claustrophobia. And actually, what they don't realise is this is because of the untreated sleep apnea, because unbeknown to them, they've been struggling so hard to breathe during sleep. That then has a knock-on effect. My own mum was claustrophobic, and I often wonder how she would have coped with the mask. I think the important thing is to tell yourself that mask is your friend. It might not look like the type of friend you want to go to bed with every night, but I can promise you that mask is your friend. And although, while you're away, it's obviously, not nice when new to CPAP, but I can promise you that when you go to sleep, that's where you know that you no longer have to be on your guard. You're no longer going to be struggling and to try to work hard to keep those oxygen levels up. But easier said than done, I know, because sometimes, when people have panic attacks, claustrophobia or whatever, and it's gone on for years, it does become a pattern, a way of life, a way of thinking. So, obviously talk to us, talk to other people in our groups. Helps, talking helps. But if you're really, really struggling, I can highly recommend, and it's not an affiliate link by any means, and I've used it myself, is the DARE program. Look up DARE by Barry. Somebody, I forgot his other name. He's Irish. It really is good. It's helping you deal with daily anxiety, accepting it, and I would highly recommend that. And obviously there are lots of other therapies, CBT therapy, but just try to tell you, I remember years ago when I had myself, when I did need some counselling, not knowing I had sleep apnea, I always, it's like he's still sitting on my shoulder, is Paul, my CPN, And he said, Kath, tell yourself sensible thoughts, you know, and that's what we've got to do, which isn't easy when we're suffering. I know that. Tell yourself sensible thoughts. And I always remember the other thing he said to me was, if you could just take 3 little words out your dictionary, everything would be a lot better. But what if? Because I used to say that every week. But what if it don't work? But what if, you know? So, you know, ask for help. There is help out there. But mostly people will get over it, believing and knowing that they're going to be safe, you know. And without that mask, I can promise you you're not.
Cool. Well, we've just got 5 hands up. So the initial test for diagnosis with the wrist and finger meter, does this give you the oxygen levels at night? And that's how the diagnosis is made. One for Sam, maybe?
Yeah, I mean, there's lots of different ways of doing a sleep study, and the little wrist watch does just do oxygen and pulse rate. It's more of a screening tool, I would say. It doesn't really diagnose oximeter. Yeah, I wouldn't really say it diagnoses sleep apnea, because it'll give the consultant an indication that your oxygen levels are dropping at certain times. But some people with sleep apnea don't drop their oxygen levels that much. It's more the interruption of the breathing, etc. So yeah, it can be used as a tool for sleep apnea, but it's not the best one. Ideally, there should be a microphone and a nasal cannula so that we can view your breathing and look at any interruptions in your breathing, obviously, and hear any snoring related breathing arousals.
Next one, I get thick saliva buildup, and using the BiPAP makes me wake up after an hour or 2. I tend to feel breathless but okay when sitting up and take my mask off. What causes this, and any solution? So thick buildup of saliva.
Yeah, I mean, build up saliva is quite common with patients with using, especially BiPAP, but CPAP as well, because it's obviously blowing air into your mouth. Some people, it gets dry. Some people get an excess saliva. There is ways of, you know, sometimes you can just put a mask liner on, which will absorb some of the saliva. That will then just take that away and stop the discomfort. But if it's a lot of saliva, you can get medication prescribed that will dry it up a little bit. You've got to be careful with that, because you don't want to go too dry. But it could just be the pressure. You might not have your mask fitted correctly, so it's leaking a little bit more, and it's just making you dribble a little bit more. But yeah, that, you know, just talk to your clinic. They'll suggest and check your settings and make sure everything's running as it should be.
One for you, Kath. I'm just conscious of time. Does CPAP have any impact on central apneas?
Yes, it can do. If the person means can it cause it, and this is why, you know, don't mess about with your pressures. Speak to your hospital. Some people, you know, we heard, oh, I was getting pains in my stomach, so I lowered my pressures. Please don't do that, because I also know somebody who did that and ended up in hospital with a heart attack. And it was discovered later that his sleep apnea wasn't being treated. So sometimes, if the pressures aren't right, then if you mean that you've seen some evidence of central apneas on your machine, remember that the machine, you know, it can only interpret what it thinks are central apneas. Sam will know more about this with the clear airways that some of the machines do actually give results on, don't they, Sam? Yeah. And sometimes it doesn't mean that they've got central sleep apnea by any means. It means that the pressures just need altering, so you need to speak to your clinic about that. Is that what the question meant? Because I haven't read the question. Is that what the question was asking?
Yeah.
Can the CPAP cause? Yeah.
So we've got a couple of other high ones, then we'll have to close off for the night. One says, hi, I'm not obese and I don't have daytime sleepiness. What treatment apart from CPAP is there, please?
There is, you've got your lifestyle changes, so the stopping smoking, losing weight, etc. Or you can have a mandibular advancement device, which is like a mouth guard. They are not normally available on the NHS. You have to purchase them yourself. and they can work out quite expensive if you have a properly fitted one. In some cases, people have surgery. It depends on why you've got sleep apnea. If you've got tonsils, you can have them removed. That sometimes can help, but it is worth discussing with your clinic because they'll obviously know you best and why you've got sleep apnea, to what treatment is available for you.
And what determines the need for an auto machine?
In my clinic, it's the consultant. He decides which, but generally it's people who he might look at it and think, actually, I think they've got sleep apnea. It looks like they've got sleep apnea, but we're not really getting a really good reading here. So let's put them on an automatic machine. All their symptoms and all their signs point to it, but maybe the study was a bit inconclusive. So sometimes they do that. But I know some clinics use all automatics. I think it really is very clinic dependent.
Yeah, sometimes it just comes down to clinic budget and what they can afford. They're
very expensive, so yeah.
I'd have to say probably the last one looking at the time. Why are sleep doctors and neurologists reluctant to prescribe medication to assist with sleep?
I think it's because there's all the CPAP works and these other treatments work. They're very reluctant to hand out pills and things which might not be treating the actual cause. So, you know, CPAP it's not invasive. It's not really any major side effects. You're not putting a drug into your body. So I think that's why they don't like. And also, there's not much medication that works for sleep. Really.
What we do is we get a record of all the questions. So what we can try and do is come back to people with individual answers via email. We are looking to put this webinar onto YouTube, hopefully next week. So if there's anything you missed, we want to watch it again, then you should be able to do that. Kath and Sam, is there anything sort of closing remarks before we turn off for the evening?
No, just thank you all for attending.
I'm just actually trying to answer some questions because I think if it's possible, we're not going to get through all these. Is it possible that we can hold on to these questions when it finishes, Tim, and answer some via email?
Yes, so we'll get a report with who asked the questions and we can come back to them.
Yeah, well, everybody will get the answers because everybody can see them. So if that's okay, we'll stay behind and try and answer these questions for you. Great.
In which case, thank you everyone for joining this evening. I hope you've learned a thing or two. I certainly have. And we look forward to seeing you on our next webinar. Okay, thank you everyone. Thank you. Bye. Bye everyone.